Hey everyone, welcome to the Hospital Medicine Essentials videos presented by the M4 Internal Medicine Chiefs. This video is going to be on GI bleeds. Big shout out to Troy for coming up with most of the information in this video and letting me present it to you. So the first thing that we'll talk about is just kind of an overview. So this is a really great picture that talks just about GI bleeding and kind of separates it into upper and lower bleeding. So upper would be above the ligament of Treitz, and lower is below the ligament of Treitz. And you can see all the different causes there that we'll go into more thoroughly later. I think a good takeaway from this slide is that the bleeding can be visible or occult in either scenario. I think we classically associate visible with lower GI bleeding and occult with upper, but technically they could be either. So just keep that in mind. We're going to start with upper GI bleeding. So some main causes of an upper GI bleed would be peptic ulcer disease, esophageal varices, Mallory-Weiss tear, erosive esophagitis, malignancy, or vascular causes. Both with upper and lower GI bleeds, you're going to want to get a very thorough H&P, so ask a lot about medications, any alcohol, previous GI bleeds, liver disease, coagulopathies, what kind of symptoms they've been having, abdominal pain, hematemesis, ground coffee, ground emesis, melena, hypotension, tachycardia, looking at their vitals, things like that. Definitely getting a stool assessment, and you're going to want to look for peritoneal signs as well. For the diagnosis, some labs that you're going to want to get would be hemoglobin, platelet counts, coagulation studies, liver enzymes, BUN, creatinine. The BUN-creatinine ratio over 30 is relatively specific for a upper GI bleed, so you can look for that, and then a nasogastric lavage if the source of bleeding is unclear. Main treatment things for upper GI bleed, you're going to definitely want to monitor the airway, vitals, cardiac rhythm, and just their overall clinical status. Patients should be placed NPO in case they need an upper endoscopy. They need 2 large bore IV lines. And then you're going to treat any hypotension with rapid bolus infusions. If they need a transfusion, if they've got severe bleeding, you're going to do a 1:1:1 ratio of red blood cells, plasma, and platelets. If the hemoglobin is less than 8, you're going to want to do 1 unit of red blood cells and then reassess. And that's going to be patients that have like coronary artery disease. And then if for everyone else, it'll be a hemoglobin less than 7, and so that would be 1 unit, and then reassess again. These patients all get GI consults. You're going to want to do an upper endoscopy once hemodynamically stable, and then all patients will get a proton pump inhibitor, and then if they have variceal bleeding or cirrhosis, you want to do somatostatin or octreotide, and probably IV antibiotics like ceftriaxone or fluoroquinolone. And then next we'll talk about the lower GI bleeding. Major causes for lower GI bleed, the main one is going to be diverticulosis, just because the prevalence is super high in our population. Another one that you're going to want to look out for would be colorectal cancer. Right-sided is more usually like occult bleeding and deficiency anemia, melena. Left-sided might be a change in bowel habits or hematochezia. But they don't have, there could be overlap there. They don't have to be exclusive. Those symptoms aren't exclusive to right-sided versus left-sided. You can also look out for colitis, which could be infectious, ischemic, or inflammatory, or anal rectal causes like hemorrhoids or anal fissures. You're going to get a lot of the same questions asked in the H&P, like we went over for upper GI bleed. One thing to look out for here is that 10 to 15% of patients that have severe hematochezia actually have an upper GI bleed, so don't let that anchor you to lower GI bleed. Always looking out for peritoneal signs, those types of things. Diagnosis is also very similar to upper GI bleed, but here you're going to get a colonoscopy if they're stable, unless you suspect an inflammatory process. Also think about CT angiography if there's ongoing bleeding or endoscopic contraindications. And then if the bleeding continues and you haven't found a obvious cause, then looking at an upper endoscopy. Treatment is also very similar: vitals, cardiac rhythm, clinical status, NPO, 2 large bore IVs, treating hypotension with rapid bolus infusions, and then there's the same criteria for transfusion that we already went over, and then any etiology-specific treatment as needed. That was all we have for you today. There's some references if you'd like to learn more. And thank you all.